Good to know. I'll try to say that right.
It's okay.
Scott, how are you doing?
Good. How are you all?
Good. Do you know Kristen by chance?
Your name is really familiar. I think I see your name on the hackers.
There you go.
Yeah.
So yeah, she's got it's called Green Imaging Network. Is that right,
Oh
Kristen?
yeah. I've heard very good things.
Thank you.
And how's your week been, Scott?
Oh, okay. Too busy, and I had a minor eye surgery on Wednesday, and it was a little more involved than what I expected it to be. So,
Oh,
feverishly playing catch up.
Are you gonna be able to see?
Oh yeah, I can see. You just don't want to see me right now. I look like I've been in a bar fight.
No worries. So yeah, Kristen's going to be the one that shares her solution with us today.
Cool. Yeah, I've heard good things from the folks at Rosen.
Oh yeah, do you work with Rosen Health down?
we do. We work with them in two capacities. We are their solution. They use Orlando Health in that Kissimmee area because they got good hospitalization rates. But if it's imaging outside of that area, which it pretty often is, we do their imaging. And then also they are the near site clinic for School District Waukegan County, which is kind of our textbook case study. It just keeps getting, we're so tired of that study, but it just keeps getting better and better. So there's nothing we can do.
That's good news.
It is.
Yeah, hospital-based anything is just costs are out of control.
We do have a few that are starting to see the light and realize that it's easier to work with us when they actually get paid than to try to collect from patients after the fact. So we have DeSoto Hospital in Florida, Orlando Health actually contracted with us. We have Baptist in San Antonio. We're starting to have more and more hospitals being willing to work with us.
Hello, Martin.
Oh, Martin. Hey.
How are you?
Oh boy, I'm fine. I'm trying to get video here. It's a big ask. There it goes.
How was your new year, Martin?
It was good. I hope yours was.
It was, yeah.
Sorry I missed the last meeting.
No worries. I think we had RX Protect present at the last one. Talked about an importation solution that was creative. And Scott, thanks for inviting, was it Terry?
Yeah.
Terry was very helpful. He had some very good questions that I'm glad he asked.
Yeah, Terry is very, very well, he's just off the charts when it comes to pharmacy and PBM stuff.
Yeah. Do you ever work with Costco's PBM?
We have. They choose not to engage with us because, the methodology that we put out in the marketplace puts the PBMs at risk for their network pricing. So some of them will engage and some of them won't. And, they've just chosen not to. They're
What
good
do you mean by it
organization.
puts them at risk? How do you pass the risk on? I like that idea, actually.
So, we don't get hung up in the terms transparency, pass-through, fiduciary when it comes to PBM. In our mind, those are all just marketing terms.
Right.
And a lot of the pass-through PBMs, the reality is their pricing sucks. And they're getting marginalized by the rebate aggregators. So, while we don't chase rebates, that if they have a strong formulary, they're missing a lot of rebates or they're getting excluded out of the market by the big three who, really don't want them in the rebate game. So what we do is we require that they give us a unit cost per pill that's fixed and guaranteed on the generic side. And, so we don't care if they pay CVS or Walgreens $3 a pill for a 20 milligram of atorvastatin. If the contract says they can only charge the client 4 cents a pill, they can only charge the client 4 cents a pill. So
Gotcha.
it pushes that risk back on them to go out and deal with what they have to deal with on their side of the ledger.
Interesting.
It's very effective.
Yeah. Frank, welcome.
Hi there. How are you, Daryl?
I'm well. How are you?
Doing okay. Getting snowed upon again.
What's your snow depth now?
We got 7 feet in the month of January.
And what's your current snow depth?
At my house, it's about beyond waist deep.
Is it?
But 7 feet cumulatively, we're like 140% of snowpack. So
Yeah.
really, really good. And a lot of it's really wet, heavy, moist snow, which
Yeah.
has a lot of water.
But that's impossible. We have global warming. You can't possibly have that much. It's impossible.
It's kind of funny that especially January isn't the big month. It's April,
Yeah. Well, there's so much carbon in the air that it's impossible. So you're just delusional. So that's just, that's just the way it is.
Martin, you getting any snow in North Carolina?
Nah, but it's been pretty cold this winter though,
Has it?
Yeah. It was real cold in January. About a month ago, it was really cold. We had a
Patrick, how are you doing?
here.
You hear me?
I can.
Okay, good. I don't know if you remember me.
I'm trying to remember you. Help me.
I'll turn on my camera. I was I work for a school district. We've been doing
yes.
some healthcare.
Yes,
Yeah.
with Matt.
I haven't. Yeah, well, I wasn't working with Matt Ork, but Matt and I
But
know each other.
you got invited, or it was,
Yeah.
I think we matched through Matt. Yes.
Sure. Yeah. Yeah.
No,
Yeah,
I'm glad you're with us today.
I've not been involved much, but I've kind of tried to follow in the background a little bit. So
You are always welcome to join us. Steve, how are you doing today?
Doing great, really good.
Good. Why don't we, Patrick, when you joined us before, did I give you a chance to introduce yourself?
yes.
Okay, so you've had a chance to introduce yourself. I think, who's calling in on 1720-474-7724?
Michael Jurgens, Daryl. Good afternoon, everybody.
Michael, how are you?
I'm excellent. Thank you for asking.
Good, good.
Daryl, Steve here. In terms of meeting mechanics, at about 2:30, I'll take off the Zoom and just join by phone, okay?
That's fine. Yep. So I think everybody here has had a chance to introduce themselves. Kristen, do you want to just quickly introduce yourself? Don't go into your presentation yet, but this is your first time, right?
It is, absolutely. I am Kristen Dickerson. I am founder and CEO of Green Imaging. More importantly, I'm a practicing radiologist. And I think that's really one of the things, doctors getting back, it's in face-to-face with patients and, with the people paying for the patient's care, which is often employers, is really important. Doctors abdicated their responsibility for the cost of healthcare a long time ago. And a lot of the unique things about our model have to do with the fact that, I've been a radiologist who's been in the business of healthcare for a long time and have come up with a solution that's imperfect, as is but it brings the important players back together in the room.
Nice. And tell us, where are you located again, Kristen?
I'm in Houston, Texas.
Houston. That's right. Great. Awesome. Well, let's start off with just a discussion around what may be new. Any comments from our last presentation? I am trying now to send the link to the recording of twice a month on the invite that I send out for the next meeting. So if nobody's seeing that, just want to let you know, we'll try to keep doing that. The recording from the previous one will be on the invite for this next one.
Do you want me to also talk about the group?
Oh yeah, Tommy, that's a great idea. Why don't you just share what we're doing with a LinkedIn group for this group?
Yeah, so as you guys know, being on this live, we've invited particular people to be live in this. aspirational advisory group as we build a good core group of people that share our values. But we want to also introduce this concept to other providers. So as Daryl will send you out the whole link in the email so that you stay up to date. We've created a providers group on LinkedIn, and we'll be sending out the training portion. And then we're looking at introducing aspirational healthcare to other providers and brokers that are looking to get into this space. So,
And employers.
and yeah, employers. So we have an employers group and we have a providers group right now. No, employers group and an advisory group right now. And then we will be adding a providers and a service one so that everybody can collaborate and the trainings are up in the same space. So if you'd like to be invited in those groups, just go ahead and shoot me your LinkedIn link in the chat and I'll make sure that you're invited to those groups.
And what are the names of those groups? Just so that it's just Aspirational Healthcare Employers Group, right? Or Aspirational
Yeah,
Healthcare
so what I'll
Advisors
do
Group?
is I'll send the link to the groups right now in the chat. So anybody who wants to just go in and volunteer invite, then we'll accept you in. The employers, we are trying to keep to just employers. But the other one I think is pretty open, right, Daryl?
Yeah, and any of you that have employers that you want to invite to that, let us know and we'll be happy to include you. But the whole idea is for employers to communicate with each other, brainstorm with each other, just like we have, some that may have already adopted the model, some that may be adopting it, some that may just want to learn about it. So a chance for employers to get on both the LinkedIn group, but also these meetings to just talk about how do we make healthcare more customer centric.
Daryl, I have a newsletter I send out to our employers. We have almost 1,000 employers we work with. So if you'd be okay with my sending the link,
Absolutely, yeah, that'd be
Absolutely.
awesome.
I'll include that.
That'd be
Yeah.
awesome. I've had a couple of really interesting phone calls from healthcare journalists. And I'm going to create a aspirational healthcare journalist group. It's been very interesting to hear from healthcare journalists how interested they are in this concept. And quite honestly, how frustrated that they've never heard of NUCA before. Here they spent a career in healthcare journalism and have never heard of NUCA, the best healthcare system in the world. So it's been some fun conversations. So we're going to try to get some journalists together and just, what can they do to help us move this movement forward?
A lot.
So with that, I don't think we have anybody but Kristen who's new to the group, so we won't have to do any more introductions, but would just love to open it up and say, who's heard of some maybe in the last few weeks or haven't brought up before, just some new innovations that you may want to share with the group or questions you may want to ask of the group. Let me start things off to see whether anybody has any comments or discussions they want to have about last time's presentation about RX Protect and the idea of importation. That was a very interesting dynamic conversation last time about, is it okay to use an importation vendor? I'd love to hear thoughts.
Yeah, I also have a comment with a conversation that I had with a broker in Chesney, Wyoming. So whenever I would like this group's opinion on what he said and he advised and what he's finding successful in his area. So whenever you want me to discuss that.
Let's address the importation, the one from last. Anybody have any thoughts or comments or anybody using importation vendors? I'm just curious. Nate's not on the call. I'd love to hear your thoughts.
Are you talking about like basically using like foreign pharmacies to bring in meds? Is that what you mean?
Right. So RX Protect presented last time. They're an importation vendor. They only get through McKesson and they only go through one pharmacy in Canada.
Okay.
But they're dropping specialty drugs by like 60%.
Yeah, we've been doing, we use a different, I don't know if this is the right place to say it, but we're using a vendor does foundation programs and then also bringing in, doing Canada pharmacy piece. And then we're also doing copay maximization, if you've heard of that. So
Well, and are you using, is it? I'm drawing a blank. Frank, help me out here. What's the group in Indiana?
RX Help Centers.
Eric's Help Centers. Yeah. Are you using them, Patrick, by chance?
no, we're using Scout RX.
Scout RX. Okay.
But what was the other one? RX Help Centers?
Yeah, they're very much the foundation. So they'll go and get the denial letter from the manufacturer, and they'll go out to philanthropist groups and associations and get a
Yeah.
lot of drugs paid for, which saves both the plan and the individual.
And it's called, what is it?
That formula for me, I mean, Daryl, I've used a combination of ProAct, Paid Health, and Canna RX.
Yeah.
And Canna RX will go international, not just to Canada.
Yeah.
But I have not found a combination utilizing RX Help Centers and, I mean, with RX Protect, who kind of oddly enough is willing to pick up the scraps that RX Help Centers, for those individuals they cannot help. Usually it's kind of all we want, all or nothing.
Right. And he's very flexible.
But, all the companies like Paid Health or RX Protect that provide specialty drugs, it is at a reduced cost, but it's not at a zero cost. And, then they add their 25% fee on top of it. So, in my personal opinion, I think the combination of RX Help Centers and RX Protect is terrific. In fact, I just had one on a client just this week where they got a denial letter and from RX Help Centers, and in 5 days, RX Protect was able to deliver it was Humira, was able to deliver it to the member. The other thing is too, that as you write these plans, number one, the language for stop loss carriers obviously important, especially if you're writing in the plan doc that you're excluding specialty. But in addition, what Daryl, our mutual client, wanted was they want the out-of-pocket that any member might incur with either one of those organizations to be applied to their deductible and out-of-pocket.
Right.
So we had to put together a MERP, which also we want covered under stop loss for consideration, as well as the TPA, doing the accounting and making sure that those numbers, those expenses are applied to the member as well. So, it's kind of, you got to make, I guess for lack of a better way to say it, you got to cover your bases to make sure that any anomalies don't occur and something falls through the cracks. And while the plan may pay for it, in my opinion, stop loss on these drugs is really, really important.
Yeah.
So it's been a learning curve for me in the last few months for sure, to make sure all those bases are covered and there's no holes to fill.
I felt.
Go ahead.
Yeah, just a thought. I feel fine about the RX Protect. International aspect doesn't bother me in that regard. Canada aspect, dealing with McKesson, that pretty well takes care of that one for me. And the combination, as Frank just described, of RX Help Centers, who has really delivered amazing results for us, but also back teaming it with RX Protect so that they can pick up the ones, if there is one out there. I'm sure there would be at some point that RX Help Centers can't help on, then that would be a good combination for sure.
Yeah.
So clarification, so RX Help Centers, they're basically doing the foundation program?
Yeah.
And that's strictly it?
Well, yeah, I mean, they basically look to see if they can get the entire drug paid for by someone, and it benefits both the plan and the individual.
And their secret sauce is where they get their money, and it's coming from grants, foundations, wealthy investors, disease management companies, drug manufacturers and the like. But yeah, that's their secret sauce. And
Yeah.
knock on wood, I mean, I've had them in place with clients for 7-8 years and they've delivered handsomely.
And I'd like to add a thought on that. Bill Spratford, the owner, fellow you talked to, you can, first class, and you know.
Good guy.
Yep.
So RX Protect does what then?
So
They-
if there is a drug that RX Help Centers just can't get for free, RX Protect is willing to step in and get that drug through Canada at their reduced prices. And
Okay,
they take, the only thing they get paid is if they get used, and they take a shared savings of between 20 and 30%, I think is what he said.
Okay. Does anyone doing a copay maximization then? Where you know how, like, for example, Humira will give a copay card to an employee that, you know, so that, you know, if your copay is $200 for a specialty drug, they'll give the employee that's getting Humira, for example, a copay card to cover that $200. So the employee's getting the drug for free, really. They're not having a copay. And Humira and all these different organizations that do the copay, or a number of them, basically that number could be 200 or it could be 2,000, and they have like a limit. And what you do is you basically try, you know, you effectively, again, deny the medication, but then come back and maximize the copay effectively, so you get the maximum of what the drug company will provide in that copay.
Interesting. Anybody familiar with that?
Patrick, my experience is that while that's great for the member, you still have a claim coming in.
Well, no, you do, and that's, so you use it in a 3-tier approach. So we're using, and that's where Scout does this for us. They're doing the foundation program basically, and going and seeing first, can they get it free? Then they come back and look and go, okay, can't get it free because they make they're income ineligible, or for whatever reason. Then they go back and they look at, well, is Canada, like going to Canada, the best program or the best way, or does the copay maximization provide that advantage? And so it's a 3-tier approach is how Scout RX does it for us.
Good.
Yeah. And you know, my experience too, and just my last comment is that's 99% of the time, if RX Help Centers can't get it, it's because someone exceeds that 400 to 600% of the FPL.
Right.
And so that's where to have the backstop of RX Protect, who's willing just to pick out, like I said, pick up the scraps, to me right now is a pretty good mousetrap.
Yeah, and that's what Scout is, and that's what I'm saying is Scout's doing this. Sounds like Scout's doing what you're doing as well. It's a product you might want to look at.
Yeah. John, I'm trying to remember, John Draper, have you been on a call yet, or is this your first time?
No, I have been on a call.
That's what I thought. Okay. In just a minute, I'd like you to introduce Kristen. But in the meantime, let's give Tommy just a minute to bring up her question. Tommy, are you there?
Yeah, this sounds insignificant compared to what you guys were talking about, but I just thought it was very interesting. I actually met a broker yesterday who is trying to do his own version of aspirational, meaning he wants to be more aligned with the employer and he wants to give them choice, but he has never heard of our group or heard of Innovative Brokers. He's fairly young. He's only 28. He's been in the industry for only about three years, but he's already built a team of 6. And one of the ways that he has implemented some of the ideas that we've talked about is he's told small groups of 20 or less employees, don't do a group insurance, just bring all your employees to me as an individual insurance. And I'm not sure how that works, but I did invite him to the group to come learn more. And I thought that was just a very interesting and unique tactic. And
so he's basically saying to the employees, just come let me write an individual policy for you individually.
Yeah, he's telling the employers, let me write an individual policy for your employees and then you just pay them cash and you'll pay less as an employer versus a group group policy.
Anybody familiar with that space?
Are we talking about an ICRA?
Yeah.
It would have,
Did he say ICRA? I mean, that is kind of why an ICRA is created, but did he say anything about using the ICRA?
he did not, but this is the one that I'm going to try to have a lunch between you and him, Daryl. So we'll find out more. I just didn't know if anybody else had heard about this, and I don't know the questions to ask. And so that's why I wanted some feedback if anybody else was doing something similar, and then I would know what questions to ask.
John, you've been doing an ICRA, haven't you?
I have, trying. I've not been successful yet, but we're definitely at the conversation stage with an ICRA. And yes, I'm a believer in ICRA and healthcare sharing. It's a combination, but
Right.
having some nice conversations, but haven't landed one yet.
Tommy, you might want to research the ICRAs. One of the things that's kind of fundamental with that, notwithstanding the policies that are available in any given county and state, but you need a platform, a portal, an administrative platform for the employer to handle payments to the insurance company, and also the same organization would have an employee portal for them to shop, compare, enroll, all that stuff. So I've vetted a handful of different platforms and come up with a couple that I would deem to be
That would be very
good.
helpful. I'm only familiar with a couple. I've only talked to one. So if you've actually had a chance to visit with a number of them, I'd love to know who those two are.
Yeah, fundamentally, the difference is that several of them send out, individual EFTs for each employee. So, the employers, seeing they're trying to reconcile their bank account, they're seeing all these single entry EFTs.
Oh, really?
Yeah. Whereas others will send one invoice, the employer sends one check, and they will disperse those payments to the 2 or 3 or 4 insurance companies that employees actually select.
Yeah, which makes all the sense in the world.
Yeah. So there's a organization over in Summit County, Colorado, over in Frisco Vale area, called the Peak Health Alliance, and we got certified by them to sell their program, and as a result, I had to go in and find the platform, the administrative platform. So
that's no relationship with Peak Med, is it?
it's called the Peak Health Alliance. It's essentially they've aligned with Centura Health, which is the largest hospital system in Colorado.
Right. Okay. Well, I just know there's a Peak Med direct primary care program in Colorado.
Oh, by the way, Centura was the other party in the Colorado Supreme Court decision. They're on the losing end of that last May.
Right, the one that we talked about. Okay, well, with that, why don't we, unless anybody's got something they want to bring up before I give John a chance to introduce Kristen.
Yes.
Well, John, since you're the one that introduced me to Dr. Dickerson, why don't you give her an introduction and we'll let her share her solution with the group.
It's my privilege. Dr. Kristen Dickerson is a healthcare rock star, I believe. She is a graduate of Baylor University and MD Anderson, cut her teeth there, training at MD Anderson, and she went out on her own in 2012 and started Green Imaging, and so she's been helping self-funded employers, and she works quite well with the Free Market Medical Association and all the players there. She insofar as what I'm excited about what Kristen is doing is that instead of like direct contracting, she can do direct contracting with radiologist groups in 50 states and help people that, whether it's breast diagnostic imaging or screening with $0 copay. She actually has a great study she can tell you about south of Orlando in Osceola County. She has a great case study in which she saved the school district over $3 million in the last year by doing direct contracting. She's works quite well with Harris Rosen, if you familiar with the Harris Rosen story, but 50 states, 1,700 providers. She it's different because she can bolt on to a self-funded plan at any time. 4.8 Google stars. Anyway, she does great concierge care for the member, handholds the member to get the care they need. And she's really, I believe Green Imaging has a very good chance to become the Travelocity of radiology, or the Uber of radiology. And in the words of Forrest Gump, that's all I got to say about that.
Well, Dr. Dickerson, go ahead and take it away.
Okay, great. Let me share my screen. Well, thank you, John. It's good to see you. Okay, so like John said, 12 years doing this. And one of the reasons this happened is that I had been a self-funded employee. I had actually run a self-funded healthcare plan. I was president of a multi-specialty group in the Texas Medical Center early in my career. And we were 20-something years ago direct contracting. We were pulling everything we could out of our Blue Cross Blue Shield plan as prices started escalating, and using it as a catastrophic plan. And, that kind of idea, as I started Green Imaging to just solve a problem in my community, which was escalating. My friends couldn't get an affordable MRI. I had an idea that I thought could solve that. And so I started Green Imaging, but I always saw getting into the self-funded healthcare market because we had done that successfully. I had done that as an employer. And so to start out with, Green Imaging is Validation Institute validated. And that means that our process of looking at claims data, extracting the facility fees, the professional fees, the HCPCS fees, putting them back together and comparing that unbundled price to my bundled price, my all-exclusive price for an exam, is validated, and our savings that we project based on this process are validated. That gives an employer a $25,000 kind of warranty if they pass their plan design through the Validation Institute, that savings is going to hold up. The really great thing about it is that there's no risk to the employer. We don't have a PEPM or admin fee. I see that, and that's really important to me. It means that I can't pay big commissions. I can't, do the kind of underhanded things that a lot of some of my competitors do. Pay kickbacks to the TPAs and that kind of thing. I want it to be transparent. I want the employer to understand that if their members don't use Green Imaging, they're not out anything except the implementation time, which is very short. And I think that makes it a very low barrier to implementation, and that we're a great first step, frankly. If somebody's self-funded, but they're not really putting in the solutions that they need to save, we're a great first step. And level funded, the same thing. Great first step. It can help them get to seeing the potential of being fully self-funded. So moving along, we do provide cost savings. We can be a safe harbor for reference-based pricing. I, as a radiologist, hate reference-based pricing because it's a broken reference. It undervalues, Medicare undervalues some exams, overvalues others in the radiology space. And we've taken basically 60% cut in imaging over the last 10 years to offset the, increases in E&M coding. And you can't tell me that $237 is the cost of an MRI. I had to shut down my imaging center in Houston where I was offering a $250 MRI because I was going to have to charge what everybody else in town, that I'm contracted with was, and I would be competing against my own network. So, that's not a viable price. And so that said, we can be used instead of reference-based pricing. For everybody that goes to Green Imaging, zero out of pocket. They may be subject to a balanced bill with a reference-based pricing plan. And we decreased the noise in that setting. Standard benefits brought us in, there wasn't a lot of savings in apples to apples for them. We were I think there were 40,000 savings in when we looked at what they were paying for an exam in the reference-based pricing space. But on the other hand, they had the administrative fees associated with it, and they had lots of noise. And so we got rid of that noise for them. We provide access to imaging, more and more of the advanced imaging that's really a lot of things you may not have heard about: elastography, the new cardiac MRI, coronary CTA. All these emerging technologies are only available even in Houston, Texas, in the Texas Medical Center at 1 or 2 facilities in the city. And so we know where those happen. We know where we can contract and get good prices on those things that can be astronomical in the wrong setting. And then we provide better care, frankly. There are not many providers on the planet that have 4.8 Google stars, especially when they're relocalizing care. I'm dealing with patients who already have an appointment. Their orthopedist has already sent them down the hall for an MRI, and we're going and grabbing that order and rescheduling them somewhere else. And so we really, we understand the value of the members walking away thinking, wow, that was a great experience. That's what has made us successful. We want to know what the pain and the friction points are in the existing plan. If they've got cost containment in place, what kind of steerage are they getting? We want to beat that. And then we have this that we're calling radiology medical management, because we're radiologists and we're reading the majority of the studies in the network. We have the unique opportunity to help with other solutions. So if there's a bundled surgery option, or if there's a cancer plan that's associated with the health plan, we're the first person who knows when we're reading the study that somebody's got an ACL tear or a new ovarian cancer. And especially in Texas, where we're working with Next Level Urgent Care and Texas Medical Management, which is Texas Free Market Surgery, and we're all in the same health plans together, we're able to communicate as providers in a very unique way and help each other, make sure these patients are getting the optimal care and not getting sent down the hall to to somebody's golf buddy for the orthopedic surgery, that they're getting to the high quality, affordable option. This, claims data analysis is very complex for imaging. There are very few people who do it right. I have had TPAs actually do analyses of us versus Aetna that were totally wrong and send them out to brokers. Unfortunately, a lot of those brokers know us and saw that and told me about it, and we were able to get it retracted, but it happens all the time. And actually, if you look at Aetna's claims data analysis that they send out to their employers, I was talking to a big potential client, and he said, no, but imaging is just 6% of our imaging set. And I said, that would be totally strange. That's not what we find, in the claims data analysis that we do every day. And I'm sorry, I've got the yard guys here on Friday afternoon, but I'm going to hold the mic closer. But what we found is that Aetna only puts the facility fees in that imaging bucket. The professional fees are over with the physician fees, and the HCPCS codes are over with the medications. And so when we actually rebundled, it was Quest Diagnostics data, they were spending about 11% on imaging. And so that's a much more realistic number. And that's what we find all the time in the claims data. We do have a template. So if you have a potential client that, one of the easy sells is to get the claims data and let us, compare apples to apples and really show them what the potential savings are. This was actually a pretty big shocker to me. This is mammograms. We know that 3D mammography there are fewer callbacks, which is great for women. They're not having to take 2 afternoons off to have a mammogram. They're only having to take 1 off. And the idea was that was going to hold down cost as well. Well, no, it hasn't held down cost. And there have been a couple of reasons. Actually, the technology is more expensive, and the radiologist's time in reading the exam is significantly greater, but mostly it's been the mergers and acquisitions in the imaging center space, and especially in the radiology group space, where these private equity groups are buying up imaging centers and radiologists and aggregating these contracts, reviewing the contracts, and then holding the claims and billing out under the best old contract. And that's what we're really seeing, escalating the pricing. So whereas 250 to 425 is my typical contracted rate for a mammogram, and probably what most of us would expect to pay in this claims data set, when we took screening and diagnostics all in, the average mammogram was $650. And then when we look at ultrasound, which, people consider low complexity, we watch the price of CT and MRI in a health plan like we did the cost of gas, but nobody was watching what happened with the lower complexity exams. The average ultrasound, which I would have expected even down the hall at the hospital to be maybe $400 pre-pandemic, was $1,381. The significance of that is you just got to understand this for in a health plan when 40 to 60% of Americans are not getting care or delaying care because they can't afford it. A woman whose screening mammogram would have been covered by a MEC in a health plan frequently does not have coverage for, or doesn't have, first dollar coverage for a diagnostic mammogram. That means a woman with a lump in her breast is going to present, average deductible, let's say, $2,500, $3,000. She's going to be paying over $2,000 for her mammogram and her ultrasound to get this worked up. And most people don't have that right now to spend. And so that's why we're seeing these delayed cancer diagnoses. I just think the numbers are here to prove that up. And it's really a travesty with how much we spend on healthcare in this country. CT scans are staying pretty stable. We see them average between $1,000, $1,400. The problem with them isn't the average price, it's the prevalence. When somebody goes to a freestanding ER, they get a neck, chest, abdomen, and pelvis, and sometimes the head as well. If they've been in a fender bender, you add that up and you've got a $5,000 bill right there. 3T MRI it's a very good tool for some things. If you look at what orthopedists and neurologists are putting in their own practices, they're always 1.5 Tesla magnets. There are a few things that I read. I would tell you for endometriosis, 3T is remarkably better. In fact, I think we probably on a 1.5 undercall 50% of endometriosis. So it's something that, a family member, I would say pay up if you have to go get a 3T. There are a few other reasons to get a 3T. This was actually a pediatric patient and needed a neurologic workup, where they're looking at neurons and their distribution in the brain. Yeah, it's a better study. And so we went out and shopped for this member where we don't have a contracted center. We go and shop for care for members. And so in this setting, we went to the two pediatric hospitals first. They were going to be in the $7,000 fee range. One of these didn't even include professional fees at $6,700. And we were able to get this at an independent imaging center read by a neuroradiologist for $700. And so that's the differential. And it's the same study and it's the same machine. And frequently the same radiologist, mind you. PET CT, in my world, we get them for $1,400, $3,000 if they're a traditional radiotracer. Some of the new radiotracers we're seeing, even in the independent imaging centers, we're seeing paid out at $20,000. I can usually get those for about $5,000. PMSA is the hot one. It's being used for prostate cancer. And it I'm getting for about probably $6,500 all in compared to 20-something thousand. But right here in this claims data set, these were the PET CTs they had. The average for the scan itself without the radio tracer was over $10,000. And then radiographic contrast, the HCPCS codes frequently do not get properly adjudicated in claims data assessments. And this one was paid out at $8,000. That's a $25 expense for an imaging center or a hospital. And look at this, the member, paid a significant portion of that. And so to me, that's just a travesty. Fiduciary duty is just not being done in these health plans. So we do help with costs, but even maybe more importantly, access to care. Making sure a patient can get things like elastography, if, at post-COVID cardiomyopathy, that they can get the cardiac MRI. That's really hard to find. And a patient doesn't, patient's going to call a hospital and try to get a price, and they're going to ask for a CPT code. Patient has no idea what the CPT code is. We're in there shopping on behalf of these patients. We're helping, holding their hand through the process and making sure they get that care. Steerage, getting them away from the high cost hospitals to the best outpatient independent centers. Sometimes, again, we are working with hospitals, but more often it's good independent imaging centers that we work with. And then the patient experience, making them want to come back when they're under even greater healthcare stress for a more stressful exam, an acute exam. It's really important that they have a great experience with us. Again, we can be put in as a safe harbor and reduce the noise of reference-based pricing. Again, the same machines, the same radiologists are frequently, involved in these exams. We actually on Friday afternoon is our busiest time at Green Imaging. We're keeping people out of the ER. Somebody presents to their doctor with right lower quadrant pain or with shortness of breath. We're getting them in, or leg swelling. It's a suspected DVT. We can get these exams affordably and not just save on the imaging exam, but also save them, sometimes even an admission. The fact that we're 100% radiologist owned and operated is very important, not only because of the model where we're getting members and the people paying for the exam aligned in their incentives, but also because it enables us to assure quality across the network in a very unique way. We're either reading the study where we're looking at the exam, we're making sure that the patient was positioned appropriately, that the protocol was correct, that the right subspecialty radiologist is reading the study, or we have as radiologists peer review access to the images and reports. And I've only had 4, but our warranty is that we're going to make sure you're satisfied with the exam. I've had 4 exams questioned over 6 years with all the thousands that we do. 2 of them, the patient moved during the exam. We just sent the patient back and got the sequences repeated and got those taken care of. One was a woman with very dense breasts. The mammogram was basically whited out. We got her a breast MRI and took care of that. And the other one was a scheduling error on our mistake. It was a new scheduler who scheduled a patient who shouldn't have been on an open MRI on an open MRI. We repeated it on a high field magnet, got that taken care of. So that warranty is in there. It's something we want the patient to get the right exam. And it also enables us to do the protocol for the exam. So rather than this cross-coding, I just went through an event where a big client changed TPAs. And about 50% of our claims got denied, a large percentage because the TPA couldn't recognize double last names, which are very frequent in the Hispanic community. And they were denied because the patient, quote unquote, wasn't a member. And the others were this cross-coding that they do in the health plan to, quote unquote, assure appropriateness. We have a radiologist reviewing the order, reviewing the clinical information, making sure the patient is getting the least radiation, the most appropriate exam, and less contrast exposure. Cross-coding, I just can't tell you. And they kind of laughed when they brought it. They said, look, you've got this patient who got a pelvic MRI for varicosity. And I said, yeah, that's a really important reason to have a pelvic MRI. Men become infertile because they have varicoceles, scrotal varicoceles, and women have pelvic venous congestive syndrome. It's actually, they're practicing medicine with that cross-coding, and it's really disturbing. And, these members ended up getting denials on these things that were perfectly appropriate. We did get it straightened out, but there's a better way to do it. And getting physicians back involved in that process, to me, is the best way to do it. And so we are there making sure the patient's getting the right exam. And that's just another kind of, thing that makes us different from anybody out there doing this. Typically, no matter where in the country you're doing this, if it's an expensive market like Boston, where 90% of the exams are performed in the health systems, or Houston, Texas, where I think Green Imaging has really driven down the cost of a self-pay exam in Houston because we've been doing this so long. No matter where you are, we can typically save these plans 60% when we go apples to apples on the cost of the exams. When we break it down between what they're doing to subsidize the member, to make sure that member, typically it's $0 out of pocket for the member. If the member uses Green Imaging, they're subject to the copay and deductible if they use the major health plan. When they do that, we still have 30% direct plan savings, but there are lots of indirect plan savings. The down coding we do, where we take a study that shouldn't be without and with contrast and just make it with contrast, is not reflected in that number. And also the fact that so many of these patients would have met their deductible with one expensive hospital exam, and now everything else is on the plan, is another indirect savings that's not reflected here in the 60%. This is School District of Osceola County. These employees' wage increase was completely wiped out in 2019 by the increase in their out-of-pocket for their Cigna plan. The teachers union went to the school board and said, you've got to do something. You're not doing your fiduciary duty. We should be hearing that phrase spoken all over this country.
Yeah.
And they actually did something. They moved the near site clinic out of a hospital system and over to Harris Rosen Health Center at zero out of pocket. And they put in green imaging at zero out of pocket. We had projected 1.3 million in savings in 2020 based on our existing network. Once we had these 10,000 members and we had 6,000 Rosen employees to leverage, we got our pricing down by about 20%. So despite the shutdowns in 2020, we saved the district 1.5 million. The next year, the water cooler talk and people having successful encounters with us, we got it up to 2.5 million in savings. And then last year it was 3.7 million. So it's really a great story. And, again, if you bother to look at our Google reviews, you'll see those members, thanking us for getting imaging that they otherwise could not have possibly obtained, either because it would have been difficult to find the study or because they couldn't have afforded it. Let's keep going here. Implementation is very easy. We have some big companies that make it really difficult with security audits, and that's why we're going through our SOC 2 compliance voluntarily, just to be able to prove up in advance that we take that security very seriously. But like Captain D said, it was the easiest implementation they've ever done, so it can be really simple as well. And frequently we're kind of implementing as we go. Somebody will say, oh, we've got a member who needs this really expensive exam. While we're implementing, can you go ahead and do this? And we do that. We know that can be a substantial savings, and it's a great introduction, for an employer to us, that we care enough to do that in advance. Let's keep going here. This is a way outdated slide. I've got to keep thinking I've got to get this updated. We're at about 1,700 contracted centers. We have another 1,700 centers we work with on one-off arrangements until we have enough covered lives in the area to ask them to contract. Having owned imaging centers, I can't tell you how many contracts we signed that never resulted in a patient. And that's an expense I don't want imaging centers to have to go through. And besides, it gives us an opportunity to try out their quality, both their image quality, their reporting quality. And then again, it gives us a chance to work with them on a customer service basis and make sure there's somebody we want in our network. We make scheduling while on intake. A member is able to identify their preferred communication style. Email, with my mom, it's going to be the warm voice on the phone. With me, it's going to be email, and with my kid, it's going to be texting. About 40% of members they can take a snapshot of their order and their benefits card, text it to our main number, and be, within 30 minutes, be scheduled and on their way with a voucher that gives them the instructions they need, the prep for the exam, the date and time, the address of the facility, the name of the facility, everything they need to get that. Whereas on the other hand, almost everybody uses the texting feature somewhere along the way, whether it's we give them a reminder to grab a CD in case their doctor needs it, or the opportunity to confirm their appointment, or they just have a question about the exam. That's available, and it's very quick. It's basically a chat function, and they can get things answered without hanging on the telephone. We have customizable education tools and resources. These are all co-brandable and customized for the health plan. And then very importantly, we have this bi-monthly newsletter that goes out, has a timely topic, and reminds them about their green imaging benefit and how to use us. And that really works. We have about a 45% open rate on that, which typical email open rates, for very, very low. And so our members do value that. Again, it is worth looking at our Google reviews, and you'll see that our concierge staff are almost always called out by name. I think, the fact that we saw early on that warm body and warm voice at the end of the phone is very important to patient care. And actually, when we time our phone calls, and we actually found during the pandemic, the phone calls went up on average 7 minutes. People just needed somebody to talk to. And so, we're more than willing to be that warm voice on the phone. And we can be rolled out at any time. In fact, we prefer not to be rolled out at re-enrollment, because people see that as just another cost containment thing, not as a benefit with a capital B, which green imaging really is.
Mhm.
This is a deck we have that's also customizable. It's available in multiple languages. It tells the member how to use us, what that process looks like, what to expect. Most of our competitors kind of cherry pick the exams they offer. They offer CT, MRI, and PET CT. Actually, that's only about 15% of the testing that we do in a self-funded healthcare plan. The most common exams are ultrasound and mammography. And when you look at the aggregate savings, those are huge. We also have a concierge service that have KISS, the KISS card, and green imaging, alongside each other with different members. They said that yes, they will do a little bit of steerage for surgery, but they make no effort to steer for imaging, and big, huge differences in the volume of exams performed. So, people ask why the imaging centers want to work with us. And I've owned 5 imaging centers in my career. I can tell you, I know the pain points, and I really try to answer those for the imaging centers so that it becomes a flywheel. It becomes that we're the best referral source for their, of all their referral sources. So we are bringing them a clean radiologist protocol order. They're not having to go track it down. They're not having to verify insurance. They're not having to get an auth. They're, not having to collect from the member. We're paying their price, and we're paying them promptly. And Orlando Diagnostic Center, holds appointments for us, opens weekends and evenings for our members. It really becomes a great relationship. And, the more lives we're able to leverage, I don't particularly want to be a gigantic company. In fact, having 35 employees is getting challenging. But the more members we have, I'm seeing the beauty of how we're able to leverage it for pricing and get workflows in place with these imaging centers. So it does have tremendous value to be larger. And so I guess that's where we're heading these days. But it's also, kind of part of our mission is to take care of as many people as we can, as what, as long as we can do it well. And that's our hope. So I am here for any questions.
Thank you. Yeah, let's open it up for questions. I've got a couple, but anybody want to start off with a question?
Very impressive.
So maybe I'll start. I would think one of the things we really like to encourage employers to do in building an aspirational healthcare model or benefit is use concierge. And Sally, welcome to the group. You know how important those are. I would think in your role, a concierge is a great partner with you. If the members know to contact their concierge, and the concierge knows that you're involved, then it would be a great handoff. Do you find that to be the case? Do you work with a lot of navigators or advocates or concierge people, organizations?
We really do. And, we work with them in a lot of different ways. There are services that just basically want to white label green imaging. So we're communicating with them in the background. We don't want to have too many touches. There shouldn't be too many people touching a patient. It gets confusing. And so we're perfectly willing, I don't care how people use us, whether it's so-and-so powered by green imaging or, if green imaging's name is never in there, if they're getting the care that they need and the service that they need, we're embedded in a number of different products. And so, I think we go back and forth. Sometimes people never want us to deal with their patients, and that becomes a little cumbersome if we never communicate with them, because it becomes difficult with the screening exams. There's sometimes too much back and forth, but we've developed a platform that enables us to communicate with our imaging centers in the background and with clients in the background, and they can search and see where we have facilities and what kind of pricing it is. And we're trying to empower those concierge services and the people doing the steerage to work with us without noise or friction. And so
Well,
that's
do you-
the important part.
Do you find that what percentage of yours are they waiving all copays and deductibles because they're using you? Is that a small percent or is that a fairly large percent?
It's 85% is zero
Really?
out of pocket. And we've
Yeah.
had several that, like Axiom Medical, that, started out with a low copay and during the pandemic just got rid of the copay, and it's much easier for the members. The copay doesn't really change utilization, but it puts another friction point in the equation.
Right.
And that, when we really describe to somebody, okay, so we'll have somebody who say, well, I don't want to drive 20 minutes. I'm just going to use my insurance. And we'll say, well, we priced this exam closer to you. If you are not going to meet your deductible, you have not met your deductible, you may be several $1,000s out of pocket. Your employer has given you the opportunity to get this exam at zero out of pocket. That works 99% of the time. So many don't understand their deductible or a copay.
Yeah. Other questions?
Dr. Dickerson, do you go at risk for your fees?
We go at risk in that we're going to warranty that you're happy with it. We have done some capitated arrangements. Right now, it would be, I've got some great old contracts, but there's so much mergers and acquisitions that I can't promise you that I'm going to be able to get that same facility. I mean, I've just had 2 close this week, just closed doors. Right. There's so much volatility in this market and in the pricing that I've done fine. We're in Houston, I've got this very stable network. And so we've done fine with capitation, but it's really, and there's so much variability also between health plans, I would say, in kind of school districts, in lower income companies, where the average income is in the $50,000, $70,000 range, we get very high utilization. If it's a law firm, if it, other places, the time value of money changes how often somebody's going to use us. So it's really hard. I would love to do that. And we've talked about selling bundles of imaging, but that might be a good way to do it. I'm going to sell you 1,000 exams at this rate in advance. And, it would be much better for me if I did that from a cash flow standpoint. But most health plans really want that. They want it to run through their TPA for the analytics. Not that we can't just give them an 837 that they can run through the analytics. And we do that frequently if we're working directly. Just talk to a company in Miami that wants it to run outside the TPA, but they still want to import that data into Deerwalk. And so, we're able to do all of those things. I'm not sure that the market is going to be stable enough in the next few years to capitate. So
a lot of it. Other questions?
Yeah, I guess I have a question. So if I'm already direct contracting, so we direct contract with our imaging for our imaging, and we have pricing for a lot of it that would probably be fairly comparable. Is there what is there, and this is from an employer's perspective, what's the advantage of using you guys I'm just trying to understand that fully.
There's several advantages. Number one, it's that we're a single provider, we're a single source. It's really difficult to get. I can tell you that I may have 30 imaging centers in a market, and there may be 1 or 2 that does mammography, and there may not be any that do stereotactic biopsy and elastography. And the variability in what different imaging centers. Now, hospital systems are different, but then again, with a hospital system, you're subject to unbundling, where they may charge 6 codes for a HIDA scan. And, so if you just look CPT code to CPT code, you'd think you're getting a great deal. But when you look at all those add-on HCPCS codes and everything else that a hospital system is frequently going to do, and we experience that as well, because we negotiate bundles with hospital systems, and we'll say, here, you signed that this is a bundled all-in price, yet you're charging me for these 4 HCPCS codes and this and that. It's really that, and at the back end, It's the aggregated data and the savings data and the progressive steerage and the things we're able to do as a single provider. I would also say it's the down coding. It's the, 30% of CTs of the chest are ordered without and with contrast, and 0.001 of them need to be. The others, should be with contrast or without contrast. So there are a lot of, it's those indirect saving. And then the other thing is the shopping for care. You're either going to have to go shop for those bundles if it's a, pediatric patient who needs a sedation MRI, or they're going to end up running it through the plan.
Okay.
Thanks for your question, Patrick. Anybody else have? I know we're out of time, so if people need to jump off, that's fine. I'm willing to keep it open if Dr. Dickerson is, and see if anybody else has any more questions. I have a question.
I'm
as
going
it
to jump,
relates-
but I'm
Oh, go ahead,
great
Sally.
to see you, Dr. Dickerson, and was on a call with Coral earlier where they were bragging about the great work you do.
Thanks for saying that.
So, yeah.
So my question is, cash strategies is becoming a very attractive way for employers to pay for healthcare. I would think where you've already built all the cash bundles, you make that just even more slick when it comes to the radiology piece. If a navigator is trying to set up a cash pay and you've already got the bundle, and we can actually get your providers paid up front, that's a good combination, isn't it?
It really is. And I think that's it. It is the aggregation of, and, I don't consider myself an aggregator because we're doing so much medical service. I mean, we have to carry malpractice in 50 states because we meet the definition of practicing medicine when we're doing these things like protocoling. But on the other hand, the convenience of having a one-stop shop, rather than it, DPC doctors spend a significant portion of their time just working on referrals. Doctors do, just a regular medical practice does as well. The concierge do, having one resource. And you would be surprised. You look at some of these people who are providing these shopping services, they're going straight to us first thing, because, we do have that solution. And that's what 12 years, we had an advantage. We got into this market well before it was the hot thing. We struggled through a lot of years of nobody really thinking, this was ever going to catch on. And certainly how busy we are right now is showing the success of that cash pay model.
Yeah, well, that's great. Anybody else have any questions?
How many school districts in Texas do you cover?
It's hard to know because we're with some plans like that Texas Schools Health Benefit Plan, where they have a very high copay and there's very little utilization. So I would say we have direct contracting where there's significant utilization with about 20 school districts in Texas. Indirectly, a lot more school districts have access to us. But we just, we get when we're in there educating the employees and really making sure that the benefit is set up right, and they're aware of how to use us, we do so much better.
I think every school district in the country, after this Osceola County case study, would be looking at this.
It's a matter of getting the word out. It's like every employer in the country should be doing this kind of stuff. It's just a matter of getting the word out.
Well, there are a lot of barriers to it too. That, a lot of those districts have, traditional brokers. The broker, the company is sponsoring their golf tournament and their for their foundation. I mean, even that was even hard at School District of Osceola County. There were a lot of relationships there that were difficult for them to unwind. And I would say that's a big barrier. Now, I mean, I just got off the phone right before this with a locked-in broker, who understands she's got to bolt it on outside, but, wants me to present to the rest of her co-brokers. So, we're starting to get through to those people as well. But it takes, you guys are the innovators, you're the ahead of the curve. Not everybody's there.
Yeah. Yeah.
Why do we only say school districts? Is that just where people are tending to go? I mean, and that's why I'm a school district. We're doing some of these things, but my wouldn't it be private employers as well? I mean, what's the difference?
Oh, gosh, yeah. I
Yeah.
think school districts,
employer.
yeah, it goes across the board. I'd say manufacturing is really, really, and we have a huge, the unions are starting to look our way as well. You know, that is where people are hardworking and not getting the care that they need. They're hard on, you know, their work is hard on their bodies. And it's hard for them to get off work to go, you know, to get the care they need, and it's hard to afford it. I think those are the people who benefit the most from this.
Well, and on that point, you know, part of this idea of wrapping healthcare around the individual, how many of your imaging providers will go to the home with some mobile X-ray machines?
You know, we have a little bit of that we can do. You know, they're really geared to go to nursing homes, and they think about things in terms of, you know, being billable, whatever. And it you know, I think there is some opportunity there, but X-ray, you know, X-ray is going up in price. It has not been one of the things that we could really validate that expense of somebody going into the home. Ultrasound, mobile ultrasound is a little more common. I see going to the workplace as the advantage there, especially with ultrasound. There's so much good screening that can be done affordably, especially kind of post-pandemic when people weren't getting care. I think mobile ultrasound has it is something that I have a number of employers putting in pilots for bringing that into their near site clinics and into the workplace.
Nice. I just know I've had 2 X-rays in the last year, both of them, they came to my home, and boy, was that convenient.
It really can be. And there are also sometimes some quality issues with that, but
Right.
yeah.
These are both fairly simple, but yep. You can't do every X-ray at home. No question about that.
No question.
All right. Any other last questions? Thank you so very much, Dr. Dickerson.
Thanks for having me. Good to see
Hey,
you.
We'll
Patrick.
send this recording out to everybody in the follow-up. So again, thank you. Really appreciate it.
Great. And I look forward to getting the word out about your organization. I think
Thank you.
you're doing God's work. Take
Thank you.
care. Bye-bye.
Appreciate it. Take care.